Thank you. Thanks, and I'd like to thank Dr. Coleman and Dr. Furman for the opportunity to be here today to discuss some new molecules in the treatment of chronic lymphocytic leukemia. I think if we listen to the speakers that we just had this morning's session, that clearly we've made substantial progress for the treatment of CLL over the last decade, but there's certainly opportunity for progress here as well in new molecules. And I'm going to walk us through some of the new drugs. Unfortunately, time doesn't allow me to go through every drug in development right now, but I'm going to go through some that are sort of very close to being FDA approved or more promising. Now, Rick also did a nice description this morning of some of the reasons why some of the drugs that we currently use, some of the BTK inhibitors, why they are associated with toxicity. He took us through the discovery of Ogden Brutons' discovery of X-linked A-gamma globulinemia, finally to the enzyme, the kinase that is responsible for that disease, and it was that discovery that led to ultimately to translating into a therapy. But if you think about those children that Dr. Bruton described many years ago, the lack of Bruton's tyrosine kinase is not associated with many of the toxicities that we see in clinic. And so there's nothing inherent about blocking that kinase that then leads to toxicities. And so some of the new drugs that we're seeing, they're designed basically to be much more specific for the Bruton's tyrosine kinase, and as we're seeing here with this drug, acalabrutinib, and hopefully with less toxicity. I think Dr. Furman did a nice job describing all the off-target toxicities that you might see with ibrutinib, and this is a pictorial description of that, where these different enzymes are, these different kinases are inhibited to varying degree by ibrutinib, and much less to a new drug called acalabrutinib, which has made its way through a new drug application. We're hoping to have approval for this drug very soon. So acalabrutinib was first described in a monotherapy trial, and this was published in the New England Journal in a phase 1/2 study of patients with relapsed and refractory chronic lymphocytic leukemia. There was actually several other cohorts in this trial. They included treatment-naive population, and Ibrutinib intolerant, and a group of patients that were Richter's transformations or pro-lymphocytic leukemia. In the initial publication, which I'll take you through here in a second, there was a 95% overall response rate in the relapsed and refractory patients, 85% a true PR with 10% still with PR with lymphocytosis, and kind of similar results in a treatment-naive cohort. This is the patient populations that were entered onto this trial, and I think one thing, if you just look at the bottom of this table that was taken from Dr. Bird's publication in the New England Journal, you can see that a significant portion of patients had 17p deletion. There were about 31% of patients had a 17p deletion, and another 29% of patients had 11q deletion. So this was, and then these patients had a median of 2 prior therapies. So this was a fairly resistant group of patients that were that were put onto this trial. Now if you look at this, you'd think from the beginning that you were looking at some of the initial publications from ibrutinib, right? I mean, you're looking at some of the same pharmacodynamic effects that we see with ibrutinib. There's initially an lymphocytosis that occurs almost simultaneously with the decrease in the lymph node size. This is the waterfall plot, an outstanding waterfall plot of the lymph node size of patients treated on this trial. And the bottom left corner is the overall response rates. The sort of darker color is the PR with lymphocytosis. The rest is the true IWCLL based on different cohorts and dosing. But the major picture is the vast majority of patients are responding, some with residual number with lymphocytosis, but unfortunately not much in the way of complete remissions. This is similar to what we saw with ibrutinib. And then finally, this is just a time to changing from PR to PR with lymphocytosis to true PR, and that's also very similar to what I think we see with ibrutinib. This is hard to be better than this progression-free survival curve, basically a straight line across this, albeit relatively short follow-up for patients with CLL, but going out to 18, 20 months. Now, this is the adverse event profile, which I think is really what we're interested in with this drug, and it does seem to be a better adverse event profile than we were seeing with Ibrutinib. When Ibrutinib first came out, I remember thinking that was an incredibly benign drug in the patients that we were treated with very relapsed and refractory, but as it moves earlier in the course of disease, some of these are less important toxicities have come out and bothersome. So Ibrutinib, the overall impression here is that it's better tolerated. The number one adverse event is headache. But if you look at the graph here, what you're seeing is that essentially all the adverse events are grade 1 or 2. There's very few grade 3 or 4 adverse events. And in this relatively small number of people, there are not the issues of bleeding so far. There's not we of course we see diarrhea, but not colitis as you might see with a PI3 kinase inhibitor. So I think the impression so far in a relatively small number of patients is that this is a better tolerated drug, which will hopefully turn into patients staying on drug longer. So this drug has also been studied in patients that were Ibrutinib intolerant, and this was a presentation by Dr. Awan at ASH last year looking at 33 patients who had to come off Ibrutinib because of intolerance. And in this study, essentially no patients discontinued because of recurrent AE. All patients were able to stay on. There were 12 of the 33 patients that did develop recurrence of the previous experience AE, but at a very lesser extent. And so this is perhaps a strategy for patients if they're not tolerant. If they're intolerant to Ibrutinib, then perhaps they could go on to acalabrutinib. I think we've already seen this slide earlier. Dr. Furman presented it. This is another new Bruton's tyrosine kinase inhibitor that's being developed, known as BGB-3111. As he mentioned earlier, there is less off-target toxicity with this drug than that you might expect with Ibrutinib. And here we're seeing ratios of BGB to 311 in these different targets in terms of the toxicity. So hopefully this drug might also have a different toxicity profile and lend itself to easier use in the clinic. This drug has been tested in a couple studies now, but the first in human study was a phase 1 and phase 2 study where patients with a variety of different lymphoproliferative disorders were studying this dose escalation, but then there was a series of different cohorts of expansion cohorts. And we're going to focus really just on the cohorts in the darker gray here that were relapsed and refractory CLL and a few patients with treatment-naive CLL. This is the patient characteristics that Dr. Tam presented last year at ASH. The median age was 67. These were predominantly patients, 37 of these patients were relapsed refractory. There were only 9 treatment-naive patients on this patient population. Now, when comparing these studies to studies, it's important to understand the patient characteristics. So in this patient population, 6 of the patients, or 18% of the patients, had 17 P deletions or mutations, and another 12 patients had 11 Q deletions. This is the adverse event profile with this molecule. What we're seeing again is, I think, a different than you might see with some of the other. There were a number of combined events of petechiae, purpura, and contusion, and I'm going to take you through that a little bit more in a second. So a higher incidence of that than perhaps what we've seen with the acalabrutinib. There was 33% of patients had an infection. But again, just like I was showing you with the acalabrutinib, we're seeing almost all these events are grade 1 or 2 and very few grade 3 or 4 toxicities. This, of course, given the toxicity profile with Ibrutinib, people have been concerned about what some AEs of special interest, and they're listed here: diarrhea, serious hemorrhage, or atrial fibrillation. There was one patient who developed atrial fibrillation. There was one serious hemorrhage, and and there was 20% of patients developed diarrhea, although that was all grade 1 to 2. This is the efficacy summary, and so the overall response rate was 96%. As you see, there's a little bit difference in that there's many PR with lymphocytosis. I suspect that will improve over time as the data matures. There's very short follow-up on this patient population. This is the waterfall plot of the lymphadenopathy. Again, excellent response in lymphadenopathy. This is the progression-free survival. Again, just a straight line with relatively short follow-up. So I'm going to change gears and talk a little about PI3 kinase inhibitors. As Dr. Brown mentioned earlier, they went through the toxicities associated with idelalisib. Idelalisib being a pure PI3 kinase delta inhibitors, but there's 4 different isoforms of the PI3K. Copanlisib, which I'm not going to talk about today, is a PI3 kinase delta and gamma inhibitor. But one of the drugs that's recently completed a pivotal trial is duvelisib. Duvelisib is a PI3 kinase delta and gamma inhibitor. The hope here is that by inhibiting gamma, not only are we having the direct effects on the malignant clone by inhibiting delta, but we're also targeting the microenvironment, which is important for recruitment and differentiation and support of the malignant clone. So this drug has been studied in a phase 1 study with a variety of different malignancies. I'm going to concentrate today on the phase 1 experience in patients with CLL. In this presentation, you can see that over half of the patients on this time, so really a high percentage of patients, had either a p53 deletion or mutation, so 52% of patients, and the vast majority of these patients had unmutated immunoglobulin heavy chain. And furthermore, these patients also had a median of 4 to 5 prior therapies, a little bit different than the trials that I've just been showing you. So this was the experience of patients broken down, but in this we saw a 57% overall response rate. This does not include the patients with PR by lymphocytosis, which are included in the stable disease category here. So an impressive overall response rate in this very heavily pretreated patient population, and poor prognostic factors. There's an 88% overall response rate by IWCLL in the treatment-naive patients. This is the waterfall plot of their lymph node reduction. The different colors are different doses, but I think you'll agree that there's really no dose effect here, that 25 and 75 milligrams twice a day is equivalent, and 25 milligrams has been taken forward as the dose that's being done in the pivotal trials and the recommended dose going forward. So this is the progression-free survival and overall survival. The top portion is the relapse and refractory patients, and the bottom curves are the treatment-naive patients. Of course, the treatment-naive patients are doing really, really well. The orange curve is the 25 milligram dose, and the blue is is all doses. This is the adverse event profile, and so the adverse event profile is, I'm going to show a slide here in a second of the treatment-naive cohort, but this is the relapse and refractory patients. And what we're really seeing as the most common adverse event in these relapse and refractory patients is neutropenia, followed by rash and diarrhea. Now, we are seeing some grade 3 or 4 toxicities in this patient population. In the diarrhea rate in the patients with diarrhea, which probably represents colitis in this, as we see with other PI3 kinase inhibitors. There are a number of infectious events that have been in this patient population with CLL. I'll show you in a second that is much less common than patients who are treatment naive, probably reflecting the underlying patient population. So this is the adverse event profile that is seen in the treatment naive patients. Now we're seeing a more prominent issue with grade 3 or 4 diarrhea. And this is consistent with the data that Dr. Brown presented a minute ago with idelalisib, that those patients that are perhaps more immunologically competent or less heavily pretreated, that they have a harder time handling the PI3 kinase inhibitors. there's a greater incidence of rash and other immune-related incidences, including AST and ALT elevation in this treatment-naive group compared to the heavily pretreated. Now, this phase 1 study has led to a randomized phase 3 trial known as the DUO trial, and that trial has read out and was presented, and a press release was going out earlier in this year. This study was a randomized trial comparing duvelisib as a single agent to ofatumumab, and this data will be presented at ASH this year, so I hope you're all there to see it presented. I'm going to switch to another PI3 kinase inhibitor called umbralisib, or TG1202. 1202 has a slightly different structure than the other PI3 kinase inhibitors. If you look at, I'm not a chemist, but if I look at idelalisib and duvelisib, the structures are fairly similar, whereas TG1202 has a bit of a different molecule. Now, TG1202 is a pure delta inhibitor, and the hypothesis here is that this different structure leads to different toxicity profile, predominantly in a decrease in some of the autoimmune complications, such as we're seeing with liver toxicity. This is the single agent toxicity profile or adverse event profile of 1202 in not a pure CLL population. So we have to understand that when interpreting this data. But I think if you look at this, you're seeing that there was very little grade 3 or 4 AST/ALT, and there was very little AST/ALT increases overall, and very little of it was grade 3 or 4. So I think that this is a different drug. We're seeing less so that type of toxicity than we would with the other PI3 kinase inhibitors I previously mentioned. It's a little bit hard to interpret some of the other data, the infectious toxicity, because this include patients with lymphoma in that analysis. This is the waterfall plot of the patients, the single agent on the phase 1 trial. You can see that in the CLL patients, that 94% of the patients, or 16 out of 17, had achieved at least a nodal partial remission with greater than 50% reduction in the lymph node sizes. So I think very early, very encouraging data with 1202. This is a more expanded group of patients now, 165 patients with monotherapy experience with 1202, and I think that the toxicity profile holds up in this larger experiences, and this has also led to a phase 3 trial, which has just recently finished accrual, and we eagerly await the follow-up and presentation of that trial in patients with chronic lymphocytic leukemia. Now, finally, I'm going to end by talking about SYK. Dr. Furman presented the very complex BCR pathway and the numerous interactions. I'm reminded that one of the first drugs that was presented by Dr. Jonathan Freeberg as a plenary session many years ago at ASH was fostamatinib. Fostamatinib was, I think, is a SYK inhibitor, and unfortunately that drug never made it through development in CLL and lymphoma. It ran into problems along the way. But if you look on this slide, you'll see that this is the profile of R406, which is the active metabolite of fostamatinib, and what you're seeing is that it has a lot of off-target toxicity compared to some of the newer generations, in this case entosplentinib, which is much cleaner drug compared to what we saw previously with fostamatinib. And so there is one publication Dr. Sharman presented and published in Blood a couple years ago, the experience of entosplentinib in chronic lymphocytic leukemia. You would think by the mechanism of action, SYK being a very proximal member of the BCR pathway, that this would be an ideal target to go after. So far, the clinical data with a variety of different SYK inhibitors has been less impressive than what you might hope. This is the patients that entered onto this trial, with looking at 25% of these patients had either deletion or mutation of P53, another 25% of patients had 11q deletion. There was a 61% overall response rate. It seemed to work across the different subgroups, with perhaps a little bit of less impressive results in patients who who had either a 17p deletion or mutation, but not statistically significant in the small patient population. This is the progression-free survival curve, so of 13.8 months, and I think that was, for many, probably not quite as impressive as what we're seeing with the BTK inhibitors, and especially in this less heavily pretreated patient population. This is the duration of response that was also presented. And so I think that the jury's still out on where SYK inhibitors are going in chronic lymphocytic leukemia. It makes a lot of biological sense, but to date we have not seen a successful development of one of these molecules. But I am reminded, and just in closing here, that there's a place for many, many different drugs in CLL, because CLL is not CML, right? We have 5 different drugs that we use to treat CML, and all of them I think are useful. CML is a disease where there's one genetic driver of that disease. CLL has many, many different genetic drivers in a diverse patient population that I think could benefit for a variety of new drugs with different approaches. And I'll close and thank you for your attention.